Thank you, Kristen. Hi, everyone. I'm Sarah Johnson. Today, I feel a little bit like the woman, the myth, the legend, which is exciting for me. I have the honor of sharing a mindfulness break with you all. But I also encourage you, if you feel like you need a bio break or if you just need to stand up and stretch, we're going to be doing just a minute of poetry. And if you're like, that's not my jam and I need to see the sun on my face for a minute instead, I welcome you to take that opportunity instead of listening to these short poems. So I'm going to steal the screen sharing and I will give you just a minute to look this over and then I will read it to you. How do you heal? One day at a time. They say one day at a time, but you don't really know what one day at a time means until you've had a few days to think about it. Until you've had 6 months to think about it. Your first winter alone to think about it. Until you've had your first walk in March when the sun warms the moss. Until it lands just right on a weird tree, lights it up, and you notice it so vividly you can't look away. Until you can breathe again without the knot in your chest and you have to think for a minute why the breathing feels so different just now. And you realize each day since that first one day felt like everything, impossible and crushing. But you made it to the end of it, alive. And more, you're healing, one day at a time. In the heat death of the universe, when the sun balloons up and swallows the earth and everything we have worked so hard to build and destroy, the inevitable end of everything. The only thing that matters, actually, is the arm around you as you fall asleep. The only thing that matters, actually, is the coffee you share with your mom on a Tuesday. The only thing that matters, actually, is a secret shared with your best friend. The only thing that matters, actually, is the work you do in a day. The name you pick for your daughter, your favorite color to wear when it's raining, the meal your dad taught you how to make, what picture you hang in your living room. If nothing matters, as we are all just barreling through space and time on an uninterruptible path toward the great end of everything, you get to pick. You get to pick what matters. You get to pick what things, big and little, take up space in your heart. And you don't even have to pick wisely. You can pick silly or pick fun, pick wild, pick happy, pick joy. If nothing matters, anything can. And I have one bonus poem. I talked to the group earlier, and I think I went quickly enough. I'm going to look for a nod from Christine. Great. One bonus poem. I may have shared this with folks before, but I like this one, so I'd like to share it again. Our strength is in proportion to our dangers. So when we've been heroes, when we've scaled our mountains, slayed our monsters and beasts, won our fights and come home, battle scarred, ears still ringing, we collapse into the safety we barely recognize anymore, and we feel weak. Without an other to battle, it feels like we have no fight left at all. And reflecting back on our war stories, what armor we wore, what we had to be to make it back to this very place, we see our now selves through our then eyes. Weakness that would have gotten us killed. The harder battle then begins to not start a war at home, to leave our warrior where they were needed, when they were needed, when they aren't needed anymore. Saying goodbye to her is harder than forging her from steel. It felt brave then. It felt necessary. Now, the armor keeps the good out when there is less to be protected from. It doesn't serve as strength anymore. The strength is in the softness, though the softness often feels like the devil I do not know. Safety feels like a dirty trick that you just have to let get you until it doesn't feel like a trick anymore. That's my mindfulness moment. Thank you for letting me share. I'm not sure how much time we have left in our break, but I so appreciate the opportunity to share with you today.
Thank you so much, Sarah. And if you all notice, Sarah is the author of those poems, so we want to make sure that we give her an applaud. Those were beautiful. Thank you for sharing. And we had an amazing time learning on the PTTC. We've had amazing, all the resources that Kristen shared. Please make sure that you share with others if need to be. I know that one of the resources had a lot of information about different topics and things that people can actually learn. So please make sure that you can use it as a resources. Kristen and Sarah's information will be shared with the slides. Do we have a question from someone in the audience? I think I saw hands up.
I'm sorry, that was a flip.
Oh, no worries.
I did, but I will take the opportunity. I was changing off or trying to end my clapping hand, so they didn't want to end. They kept giving Sarah well-deserved ovations on their own. So
Yes.
So I'm sorry about that.
No worries. Thank you, Sharon. So yeah, share all the information that Kristen shared earlier. And as I was mentioning, Kristen and Sarah and others' information will be shared in the follow-up email along with all the slides. And now we're going into our second portion of the day, and I will be presenting an amazing friend of ours and a amazing speaker. We've had the opportunity to work together in multiple arenas, and they'll be talking about harm reduction. I know that in the previous session, we talked a little bit about it, and now we have someone who actually is going to share a lot more about it. So without further ado, I want to introduce to you Janer Hernandez, and take it away, Janer.
Yes, good morning. Thank you, Kristen. It's been great hearing the other speakers. Sarah, thank you for those beautiful poems there. They always help me to reflect on what's possible moving forward. And so just to tell you a little bit about myself, and then we'll go straight into the content area here. My name is Janer Hernandez. I am Puerto Riqueño. I'm from Puerto Rico. I live in Massachusetts, and I've worked in the field of health and human services for the last 36 and a half years. Currently, I am Chief of Public Health at a community-based organization in Western Mass, where we provide a number of health-related services, including harm reduction, substance use disorders, mental health, HIV/AIDS, hepatitis C, sexually transmitted infections, peer support, and a whole bunch of other stuff that's related to health. I am also a senior consultant trainer with the New England Addiction Technology Transfer Center out of Brown, and we are extremely happy of the collaboration with the mental health as well as the prevention TTCs represented here today. We do a lot of work in our region in a collaborative fashion. In my role at the New England Addiction TTC, I provide training, technical assistance to support the work on the ground by the many organizations that are working to meet the needs of our folks in the field. As you can see, I have more letters after my name than letters in my name. I'm a prevention specialist certified. I am licensed and certified as an addictions counselor, and I have a PhD. I also want you to know that I have a GED, and my GED I earned in prison. I am a person in long-term recovery, which for me means that I haven't used a drug, including alcohol, for the last 37 and a half years. That enables me to be a productive member of my familia, first and foremost, to be here present today and to be able to do the work in collaboration with the great people here and beyond. So that's a little bit about me. I am going to come at this piece of harm reduction from a couple of perspectives, what the research says, what lived experience says, and how do we ground this information in social justice and equity, leading with equity. And so next slide, and you'll have the slides again with my contact information. This slide here is just a repeat of what was said earlier today. Regarding the training materials supported by the grant. Our principal investigator is Dr. Rose Martin, and our funding comes from the Center for Substance Abuse Treatment through SAMHSA, and the views contained here are not necessarily those of the federal government and don't reflect them in any way. Next slide, please. So the learning objectives for this session is, but hopefully by the end of this, you'll be able to describe the philosophy, principles, and practice of harm reduction, describe stigma and the impacts on individuals, families, and communities, and third, describe at least 4 techniques and strategies for engaging people in harm reduction. This work requires that we look inward in terms of who we are, what we bring, all of that good stuff here. Please place your comments, questions in the chat. I am monitoring those as we go through, and I'd like to hear from you in different ways. Next slide. So the first thing that we need to do is to understand the structural challenges that exist within communities, right? And notice that I emphasize structural challenges, right? So if we take a look at the system of delivering services, health services, but in this case, we're thinking more specifically behavioral health services. So that's mental health, substance use disorders, and other health conditions. Those systems were primarily designed to meet the needs of white heterosexual affluent males. We need to understand that if we're going to move forward. Do we have enough services for all white heterosexual affluent males? The answer to that is no. But the fact remains, based on research and experiences from the field, is that they were designed primarily for them. So if you think about, as an example of this, if we have 2,000 residential beds for treatment in a given space, can white heterosexual males access one of those 2,000 beds? The answer to that is yes. We don't have enough beds to go around, but the answer to that is yes. But if you identify as a female, can you get in? It gets more difficult. If you're a female with kids, it's even more difficult. Female with kids doesn't speak English, nearly impossible. Doesn't speak English, female kids, doesn't have health insurance, or doesn't have documentation to be in the country. So you see that our systems weren't designed to meet the needs of everybody. They were primarily designed for one subpopulation. In our field, we've also pioneered punitive approaches to working with people. And so if you think about people with substance use disorders and mental health issues, when they begin to exhibit signs and symptoms of their disease or diseases, Many of them have been kicked out of care, forced out of care, pushed out of care very specifically by folks who are receiving money because they said they know how to treat these populations, right? We don't kick people out of care because they had a reoccurrence as it relates to diabetes and their blood sugar level is out of control. But in the world of substance use and mental health, we do kick people out of care with very little to no consequences to the organizations or the individuals who are perpetuating this harm on people. We have silos that we continue to have, mental health over here, substance use somewhere else, prevention services over there, treatment services somewhere else. And these silos affect the people in need in very significant ways, right? Think about it. Whenever you go to services, whenever I go to services in any one organization, I come in as a whole being. I don't check things at the door. Yet when we are in front of people, we have to send people across town for this, health services over there, human services here, mental health services somewhere else, prevention services, if they're fortunate enough for us to refer them even to prevention stuff, it's somewhere else. And, it creates a lot of barriers for people. And we think of those barriers and we put them on people. Oh, people have barriers with transportation. Well, that's true. But the real barrier are the silos that do this to folks in terms of having to refer people to multiple spaces and places. We have recognized that we have a workforce crisis, right? The crisis has been defined as the following in the literature: primarily white, in behavioral health very specifically, primarily white, female, baby boomer, and retiring. The people in need of services are younger and more diverse. So what we need is a more diverse workforce, right? And then there are disparities, and we have a lot of data on disparities across the country. How well do we pay attention to the disparities data when we're funding, planning, implementing, evaluating programs is a point of contention and discussion, because we're not anywhere near the point of eliminating disparities in the country, and disparities have been developing on this continent and in this country for hundreds of years, right? For hundreds of years. And then there are other structural challenges that exist within communities. Next slide, please. And so why the disparities and what do they lead to at the individual level? Their impacts are huge. We have populations that we have dehumanized, right? We talk about people as substance abusers, as addicts, as frequent flyers, as schizophrenics, as bipolar. We pathologize people in our field, and I'm not talking about people from outside of our field. This is language that exists from within. It's concerning because it's from within. Many people who work in the field, they want to attribute that language to somebody else outside of the field. But this has been, I just read to you, we are funded by the Substance Abuse and Mental Health Services Administration, the Center for Substance Abuse Treatment. You see the contradiction even in the names of the funders. Now, changing those two names takes an act of Congress, but many organizations still have substance abuse in their name, and many programs still have those names in their names, and many people within the field refer to themselves as addicts or felons and things like that. And many of us who work in the field lead. And so language leads to further dehumanization and stigmatization of people. And so stigma is a fancy word for discrimination. And the reason why I presented first the structural challenges that we're faced with is because in the US, we are hell-bent on saying, if you want to get better, all you need to do to get better is be more like Daisy, be more like Janer, because if they did it, anybody can do it. And I push up against that. And here's why. Not because I don't believe that people can get recovery, can get better, I believe in that. I am a beneficiary of all of that. But I do know that structures have been built to keep some people out. And structures have been built to allow some people to get in. And so this whole piece on pull yourself up by the bootstraps, with some people don't even have boots, right? to pull themselves up by that is impossible, or talking about just personal responsibility, those are problematic for many different reasons. So we need to look inward in terms of how we as a field have sustained the dehumanization of people, right? The further marginalization and racialization of groups who deserve otherwise, right? So the impacts are huge, and I'm sure that there are many more. Next slide. So I talked about disparities, right? I just want to provide a brief definition here so that we can ground the conversation, because I don't believe in doing this work without a focus on disparities. It's a particular type of health difference that is closely linked with economic, social, and or environmental disadvantage, very specifically, right? Health disparities adversely affect groups of people who have systemically, emphasis on systemically, experience greater obstacles to their health based on what? On race, ethnicity, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, also sexual orientation or gender identity, geographic location, or other characteristics that are historically linked and forever linked to discrimination or exclusion. I encourage you to visit the website Healthy People 2030 so that you learn more about this, right? Next slide. Some of the examples of disparities: funding for substance use and mental health. We have a lot of funding coming into our field, but we don't have enough. In the chat earlier, we were talking about prevention when our partners from the Prevention TTC were discussing, and I put in, when prevention works, nothing happens. You know why? Because prevention worked, so nothing happened, and we don't fund prevention like we should. Right? A lot of the things that we're talking about here can be prevented. Over the last, the existence of the country, $3 trillion have been spent on public health. Less than 3% have been on prevention of those $3 trillion. That should give us perspective in terms of what's happening on the ground. So we see, right, disparities in funding, in workforce, like I talked about earlier, in opioid overdose deaths, where disproportionately, right, Black, African-American, Indigenous, Latino, Hispanic, Latinx people are dying left and right in the country. Yet we came to that through a different door that I'll talk about in a moment or two. We see disparities in HIV/AIDS, in outbreaks in Massachusetts and Indiana, in hepatitis C with a 300% increase amongst young people. We see disparities in housing, in employment, in education and training, transportation, COVID-19, and many, many other examples. I'm going to pick on two of these very quickly in the interest of time. Employment. Oh, the country is at full employment, almost 4% unemployment, or less than 4% unemployment rate, and people clap. Well, the unemployment rate for Native Americans is closer to 20%. The unemployment rate for Black and African-American people is closer to 18%. The unemployment rate for the Hispanic, Latino, Latinx population is closer to 13 to 14%. And the unemployment rate for people with a criminal offender record, like the one that I have, is 27%. So we see disparities when we do a deeper dive. COVID-19, I will never forget, and I will never let anyone forget that we were burying in mass graves people in the middle of New York City in 2020. And those people were 100% poor people, because we don't bury rich people in mass graves. They were primarily people of color, all had a mental health issue, most had a substance use issue, right? There are many, many, many different characteristics of those people that we put into the ground. And then we forgot about them, or we forget about the most vulnerable amongst us, right? So next slide. So we need to think about what these things are, right? The structural and social factors that are associated with disparities, back to the structural, right? Education, neighborhood conditions, environmental hazards, access to prevention and treatment, and the entire continuum of public health. Health insurance coverage, not just coverage, but quality of care. Those are structural things, including institutionalized racism, homophobia, sexism, you name it. Those things are structural in nature. They lie within individuals, but we need to address the structural pieces, right? As we think about our approaches to these things. Next slide. So, are we talking about criminal justice? or are we talking a public health approach? The primary approach in the US has been and continues to be a criminal justice approach to a public health issue, right? Public health issues, plural, not singular. Why? Because we have the largest prison population per capita in the world at 2.3 million people. This is the largest prison population ever. We criminalize mental health and substance use disorders. Upwards of 65% of people who are incarcerated have a diagnosable mental health issue. Upwards of 80% have a diagnosable substance use issue. This is according to national data, right? 70 million people in the country with a criminal offender record. That's a huge number for a country of 340 million people. Every year, approximately 7 million people are released from county jails, and an additional 600,000 are released from state and federal prisons. If you put those two numbers together, we're talking about almost 8 million people, while maintaining a census of 2.3 million people incarcerated and 5 to 6 million people on probation, parole, house arrest. We have those people who are released have very little to no reentry services. And so many of you work within programs that have reentry services, good, but that's not the reality for our entire region or the majority of the people who are being let out. Approximately 75% of those 8 million people will be rearrested within a year, and 50% of those will do time again. And then we have this invention and social construct of private prisons and jails that are traded on the New York Stock Exchange. These are huge issues within our field. So again, rhetorical question, are we leading with a criminal justice approach or a public health approach? All of the data policies that we have point to that the majority of our services and programs lead with a criminal injustice approach to dealing with issues that can be prevented amongst population, right? Christina, thank you in the chat. And also we criminalize poverty and ethnic groups, of course, because the data around disparities about incarceration is disproportionately people of color, Native American, Black and African American, Hispanic, Latino, Latin folk, and poor people. Even the whites who are incarcerated by and large in this country are poor whites, because we don't incarcerate rich people at the same level that we incarcerate others. Next slide, please. And so we arrive to this issue of opioids and the opioid crisis, right? And one of the things that I'll have you reflect on, and maybe you can raise your virtual hand if you want to, do you believe that we have an opioid crisis in the country, right? That's a question. Do you believe that we have an opioid crisis in the country? When I ask that question across the country in many different settings, most people raise their hands and say, yes, we have an opioid crisis. So another question that I ask, so why declare a crisis in recent history? In October of 2017, the country declared a public health emergency because disproportionately people dying, right, from opioid overdose deaths. But who are the people who are dying at disproportionate rates? And why was the crisis declared? I'll give it to you in a nutshell. When white, affluent, young people from affluent neighborhoods began to die, then we declare an opioid crisis. But the reality is that we've been living in a crisis mode for decades and decades and decades and decades and decades. And if you raised your hand and said you believe that we have an opioid crisis, let me respectfully disagree. Next slide, please. And here's why. Our crisis is way more complicated than just opioids. It is substance use disorders, plural. More people die of alcohol-related disease than all of the other drugs combined, over 150,000 last year of alcohol-related disease. Over 400,000 died of tobacco use in the country. And people die of methamphetamine use, of cocaine use, of other drugs, and yes, opioids. So I don't want to minimize the opioid piece, but it's not the only thing that we're dealing with, right? And so when Daisy says intersectionality, right, it is the pieces that I'm talking about now. The criminalization, the over-criminalization of people with these conditions. We have a crisis there. We have a crisis in health. We have millions of people across the country who don't have access to healthcare. And many of the ones who do have difficulties with quality of care. We have a crisis in employment opportunity, in affordable housing, in mental health, in education. And these create multiple crises at the community level. We are responsible for speaking truth to power and not just talking about one thing or repeating things in a way that perpetuates the myth of just one community is experiencing this. There is the fact that disproportionately impacting marginalized, racialized communities, right? Next slide. Crisis of systemic injustice, social disconnection, lack of supportive infrastructure, healthcare, and the list goes on. Thank you for that. Kristen, you're on point there, as well as other folks who are putting stuff into the chat. Now, I don't want to minimize the opioid stuff. So here's a slide. Today, over 250 people will die. And I know that many of you have buried people like I've buried people from within my family, friends, even colleagues who work in our field. We broke a record a couple of years ago. Over 108,000 people died within a 12-month period. And then between 1999 and now, over 1 million people have died. Over 1 million people have died. The question is, who was dying at disproportionate rates and why declare it now? Or one of the questions is that. Now, this takes into account 1999 to present day. Doesn't talk about the 40s, 50s, 60s, 80s, 90s, right? Those are 5 decades that are not accounted for in this data, right? But the sources here are NIDA and CDC. And so it's important to recognize all of these things, in addition to all the other stuff that people are dealing with, right? Next slide. So we come to some changes that have been made at the federal level as it relates to harm reduction that are important to ground within this conversation, right? So in December of 2021, SAMHSA, CDC, and ONDCP put together a 2-day summit on harm reduction. For the first time in the history of the federal government, we were not allowed to say harm reduction. They were not allowed to fund any harm reduction stuff. So this is a huge shift in policy. I happen to be one of the co-facilitators at the summit. In that summit, harm reduction was defined, the principles were established. A steering committee was established to provide input to the federal government on harm reduction issues. And there's colleagues from all over the country who are participating in that. There's a national harm reduction technical assistance that was lifted and funded and established in the country. So I encourage you to visit our colleagues in the National Harm Reduction Technical Assistance Center funded by SAMHSA. And then millions of dollars were made in the spring of 2022 with promises of billions of more dollars to follow around harm reduction. If you know anything about the federal government, is that they don't move quickly. This moved rather quickly, right? So we are in a different space. There's advocacy to include a percentage of the block grants to target harm reduction. We're not quite there yet, but there's other talks that are being held around issues of policy. Next slide. So to go straight into the harm reduction piece, so harm reduction, the definition is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use, right? Harm reduction is also a movement for social justice built on the belief in and respect for the rights of people who use drugs. Notice the second part, notice all of it, but movement for social justice, respect for and rights of people who use substances. This is somehow left out when we're having a conversation about what harm reduction is. As a matter of fact, I'm going to ask a question of everyone here. How many of you practice harm reduction? Think about it. If you said no to yourself, and some of you are raising your hand and saying yes, well, if you said no, I'm going to challenge your thoughts on that, right? Because harm reduction, nice to see many hands going up, because harm reduction has been around for hundreds of years. And many of us practice harm reduction without understanding that it is harm reduction or accepting that it is harm reduction. I wore a seatbelt this morning, harm reduction. I brushed my teeth, harm reduction, right? I look both ways before I cross the street, harm reduction. I don't hang out with people who sell drugs or use drugs. For me, that's harm reduction. I'm engaged in my recovery pathway, harm reduction. I stop at stop signs, red lights, all of those things that we do in common practice of public health measures are harm reduction. But because harm reduction has been stigmatized, many of us don't believe that we participate in harm reduction. So thank you for those who raised your hand. I'm sure that you have your own examples of how you practice wellness or harm reduction. I don't care how you call it, but it's ways of maintaining safety and security and wellness and all of those things, right? Daisy, I eat meals low in salt. Listen to that. And even in dieting, and I drink more water. I don't drink soda, right? Those sorts of things are all harm reduction, if you ask me. Again, we come up with things that are problematic in our head, and then we perpetuate those onto other people. Let me come into the principles. Next slide here, so that we can come into the principles of harm reduction, because in many spaces where we're talking about harm reduction, we're not actually reviewing the principles. And embedded in the principles are pushed back around the stigma and the misunderstandings of what harm reduction is and what it's not. First principle, it accepts, for better or for worse, that licit and illicit drug use is a part of our world and chooses to work to minimize its harmful effects rather than to simply ignore or condemn them. In other words, just say no never worked. It will not work. And ignoring it and saying people should just stop, that's simplistic. And that doesn't take into account the complexity of human behavior, right? So just saying no, good, if that works for you and you don't do any of that stuff, good. But don't think that that works on the majority of the population. It establishes quality of individual and community life and well-being, not necessarily the cessation of all drug use as the criteria for successful interventions and policies. I'm working with people that are using 10 bags. Their goal, not mine, is to go from 10 bags to 5. I applaud that. I'm working with people who are sharing injection equipment and they're no longer doing that. I applaud that, because that is harm reduction. And that is behavior change according to what people want and what they need, as opposed to what I want them to do and what I need them to do, right? Ensure that people who use drugs and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them. Now, let me be specific here. Our field is getting better at including people like me with lived experience as a person in recovery in this process. How well do we include people with living experience in the creation of programs? That is a different question. Many harm reduction programs include people with living experience. In other words, people who are actively using substances. They know things that I don't know. I've been 37 and a half years in recovery. There's no way that I can understand what's going on with people in the community right now, because I am not in that space where people are using. They have more information than what I have. And me acknowledging that is not a sign of weakness. It is a sign of strength. Our programs need to do better for including people with lived ED, but also with living ING experience in these processes, right? Let's move to the next slide. And thank you, Aaron, for the resource in the chat there that you're putting in with a very specific link. We recognize that the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities affect both people's vulnerability to and capacity for effectively dealing with drug-related harm. So you see that this comes back to what? To the social justice approach, to the structural determinants of health, you see? This is not blaming people for conditions that they did not create. In other words, poor people didn't create poverty. Hungry people did not create hunger. The unhoused did not create homelessness, right? But in society, we sort of blame them for conditions that they did not create, right? And we need to move away from that paradigm, because that hasn't worked and it's punitive. We understand drug use as a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe use to total abstinence, and acknowledges that some ways of using drugs are clearly safer than others. We've moved in society a little bit towards this. Think about marijuana policy, some of it, not all of it, right? But marijuana policy, legalizing medical marijuana, legalizing recreational marijuana, decriminalizing it, right? those are policies that have merit. The issues that I have with is still incarcerating people from minoritized communities or fining them for having possession of marijuana that wasn't purchased at a dispensary, and keeping over 30,000 people incarcerated. 2/3 of them are people of color, for selling the same marijuana that white affluent heterosexual males who own the majority of the dispensaries are putting out there, right? I digress, but that is an important piece as it relates to this being complex and multifaceted. Some people use 1 bag a day and they go home. Some people use 30 bags a day and they live on the street. Clearly, those are differences. And we cannot paint with a broad brush and think that everybody's the same, right? I call for non-judgmental, non-coercive of services and resources to people who use drugs and the communities in which they live in order to assist them in reducing attendant harm. Non-judgmental requires for us to look inward, because I am a judgmental human being and so are all of you. If we don't accept that we're judgmental, then we have nothing to do with it. But if we accept that I'm judgmental, then I can do something about it, just like I accept that I am biased, right? This whole idea that we're non-biased and we're non-judgmental, hey, that's pie in the sky stuff. The reality is that we need to attend to our biases and judgments if we're to do something about them. Non-coercive, this is moving away from that punitive approach, from that criminal injustice approach, right? Next slide. This is the final slide on the principles of harm reduction, right? We affirm that people who use drugs themselves as the primary agents of reducing the harms of their drug use. This principle attempts to give power back to people, because many people who provide services, they think that they are the ones who save people's lives. They go around, I save lives. This is why I do this work. I save people's lives every day. No, you don't. No, we don't. I don't. Here's what I do. I provide information, resources, support. I walk side by side people, and people take control of their own lives, and they reduce their attendant harm. If they so choose, they get into recovery. If they don't want to get into recovery, they reduce the probability of getting infected with HIV or hepatitis C or other things. In other words, they are the ones who are doing the work with my support. I push back on people who say, yeah, the only times that I've saved someone's life is when I administered Narcan on someone who was dying. That's the only point in time, right? It's a paradigm shift from what we're used to and how things are designed up, down, right? Telling people, oh, we're here to save you. Communities have their own solutions to problems. And to come in as the savior has been problematic for many different reasons. We seek to empower people who use drugs to share information and support each other in strategies which meets their actual conditions of use. Think about what we're doing with Narcan, right? Narcan has been around for a very long time, for decades, decades, and decades, and decades. We shifted policies, and we're providing Narcan to families, to people who use drugs and that sort of thing. What do we tell people? You can't administer Narcan on yourself, right? So we empower people who use drugs because they can administer Narcan on each other. They're not getting high in the presence of providers all of the time. As a matter of fact, many people are injecting or using other substances in private places and spaces because of stigma and those sorts of things. And what we tell people by way of harm reduction is don't use alone. Don't use alone. Use in somebody else's. And some people have problems with that because people hear that and say, oh, so you're just condoning because you told them to use or you didn't tell them to stop. It's ridiculous when we think that way, right? We do not attempt to minimize or ignore the real and tragic harm and danger that can be associated with illicit drug use. So you see that this is not about condoning drug use. This is to this famous thing that people go around saying and then they don't practice it, meeting people where they're at. Right? And I say that in way sarcastically because some people say, you know, I meet people where they're at. Really, where? In your office? When they make an appointment and they have to come to you, that's meeting people where they're at. And then when they're in front of you, do we push abstinence? Do we push, you need to change this and this and this and this and this, as opposed to asking people, right? What is it that they think they're struggling with? What is it that they think they want to change? And then how can I be supportive to those changes in incremental ways? Because change, Prochaska and Di Clemente come into this right frame here. Change is a process and not an event, and it takes time. And there's such a thing as stages of change when we think about how we focus on these things moving forward. Now, next slide. Those are the principles, right? So things to have in mind. So what are we talking about in terms of harm reduction from what? Here's a short list, and there's many other things I'm sure that you work on. But leading with the primary topic here today is substance use and mental health challenges, right? Notice that I didn't put substance use disorders and mental health disorders because some people don't have a diagnosable disorder, but that doesn't mean that they don't need help. You follow what I'm saying? And then some people do have a diagnosable disorder, whether that's substance use or mental health or co-occurring thing, but it's not just about the people who have the diagnosable piece, right? That meet all of the clinical criteria. The prevention specialists in the room are saying, yes, Aner, yes, because there's some people who don't meet the criteria. It doesn't mean that they don't need help, right? Around reducing attendant harm from overdoses. And I've spent some time talking about that, right? And it's not just opioid overdose deaths, but overdoses in general. How many of you have met people who've overdosed 20 times, 30 times, 40 times? I have. The impact, the traumatic impact of that on individuals, families, entire communities, right? The health ramifications of all of that are huge. From HIV and AIDS, sexually transmitted infections or diseases, is reducing harm for that. I was reading in the media recently, we have an uptick in sexually transmitted infections, including syphilis across the country. And this is why we think about things, as Daisy was saying, with the intersections, right? It's not just one thing, it's many, many, many different things. Hepatitis B and C, right? Criminal justice involvement. When we think about the harm that is caused by those touches, by that criminal injustice setting, we are one of 2 countries in the world that still has solitary confinement. Other developed countries consider solitary confinement as torture, yet it is alive and well. Those are prisons within prisons in the US. The institutionalization that happens as a result of the criminal injustice system and involvement are huge. Some of us don't even see them. I know people who have left, and I have similar experiences, who are no longer in prison. They wash their underwear by hand in the shower. And then they go to work, and we think that they're okay completely because they're at work and they're no longer using. I know many people who go into the shower with flip-flops on, and you're saying, what does that have to do with anything on it? Well, that's institutionalization. I know people who can't sit with their back to the door, that large crowds bother them, that they have a routine that was established behind the wall. When do I go to sleep? When do I get up? When do I eat? All of those things impact people in brutal ways. So reducing harm from all of that stuff, right? That creates the conditions for people going back. And you might say, going back where? Going back to prison. Institutionalization pushes people to go back, because in that inhumane space, believe it or not, you find a sense of belonging. That's the psychology of being behind that wall. And so when we talk about harm reduction, how do we, right, think about that as it relates to all populations experiencing many different things, right? That's an example there. Experiences with homelessness, which are traumatic, which are ongoing for people, which we refuse to resolve. And those are strong words, because how we resolve the issue of the unhoused is with housing, affordable housing. It's not rocket science. It is our unwillingness to create, as a country, as a society, livable spaces and places that are humane for people. That's where it's at. Now, I don't criticize what we have, but I do criticize what we have. You hear the contradiction. Because in many of the settings that we attempt to house people, and think about what we're doing to people, Right now, encampments, right, being bulldozed all over the country for people who are unhoused. Some people will never make it to a shelter because they don't go in. I know people who say, no, I'm not going in there. That place is too traumatic. I know females who say, yo no voy para allá. I'm not going there. Why? Rape, violence, right? I know females who will sleep during the day and not at night because of that, right? So when we think about those experiences, they come hand in hand with many of the things. And then a myriad of other health conditions and other conditions, we're seeking to reduce harm from all of that. And it's not, again, a broad brush, one stroke for everybody. It's way more complicated than what we think and what we assume it to be, right? There are some large, Daisy, I saw your comment in the chat, Daisy. And there's some large pieces of text in the chat. I promise I'll get to them, but I'm trying to get to some slides and hopefully allow for some other questions in the chat and that sort of thing. Next slide. And so harm reduction strategies and tools that you know, but I figured I'd put up, right, one of those, a slide with some of those. So we know Narcan, fentanyl test strips, those things are more controversial than Narcan itself, but it is a tool. When we think about syringe access places, right, where people go in and they get their clean syringes exchanged for other syringes, or you don't even have to exchange them. They get just clean syringes, new syringes, but they also get other care within those spaces and places that we don't talk a great deal about. And that's why the misconceptions of what happens in those spaces and places. Those people do wound care. They do testing around HIV and hepatitis C. They do referrals to treatment, to care. They do referrals to people who are unhoused. They help people with issues of clothing, with food, with a whole bunch of things. It's not just the needles. In society, we focus on the needles, and we then discriminate against people and then talk about people who embrace harm reduction as, oh, you're just enabling drug use. It is because of ignorance. We don't know exactly what's happening in those spaces and places. And then the thing that I talked about earlier, we educate families, we hand out Narcan, we tell people never use alone, we bring people in to the program implementation, development of harm reduction strategies, the programs who do it well. Some people say, we're harm reduction, and then we ask them, so what do you do? What do you implement? What strategies? And they go, no, we have Narcan. Well, and, oh, we refer people to treatment. Listen, of all people with a substance use disorder, this is research speaking, not just me, about 25% of them need treatment. The other 75% get better through other pathways of recovery. So we have to be careful with this insistence that everybody needs treatment. I'm a beneficiary of treatment. I believe in treatment. There's evidence-based models in treatment. They work really well. Are they for everybody? No. So when we ask institutions and organizations, what harm reduction strategies do you use and what tools do you use? It's very limited. And right now there's a huge shift. The federal government makes the shift, and now organizations all over the country are saying, yeah, we're harm reduction, we're harm reduction. There's a chase of dollars. And we need to take a look at practices that are grounded in harm reduction, not just chasing dollars. It reminds me of the 1990s. Some of you might not have been around. Faith-based initiative, and then many organizations said, oh, we're faith-based. It's like harm reduction changes. Oh, we're harm reduction. You name the next thing, and they're that. We need to hold organizations accountable for reaching people where they're at. So all of that said, question for people here. What do you think is the most controversial thing in harm reduction right now? I didn't even put up a picture of condoms. Condoms were really controversial in the 80s when we started this work. Like, everybody's going to be having sex and it's going to get out of control. The opposite happened. We reduced HIV infection rates. We reduced a lot of sexually transmitted infections, and it wasn't a big old orgy like, you know, some people to the extreme said it would be. So it's not condoms. It's not even syringe access places. It's not Narcan. It's not smoking equipment. It's not Narcan strips for testing. So what do you think it is? What do you think is the most controversial thing right now in harm reduction? Supervised sites. Thank you. Let's go to the next site. Violet, thank you for that, right? The next slide. No, one before that. Right, there we go. Thank you. So it's what are known as safe consumption sites, and they've been rebranded as of late as overdose prevention sites, right? To move away from the safe consumption thing that triggers people to think about we're condoning drug use, right? Now, question, how many of you have ever been into a legal safe consumption site in the country? Raise your hand. Raise your hand if you've ever been into a legal safe consumption site in the country. All right, I don't see any hands. Let me ask the question in a different way. How many of you have ever been into a bar or into a party where alcohol is being served? Raise your hand for that one. Those are safe consumption sites. You see our bias, you see our misinformation, you see our stigma at play. All of us frequent places where alcohol is being served that kills more people than all the other drugs combined. And none of us are in front of those spaces and places where signs saying, close this bar, close, right? Say no to parties. Over the weekend, bunch of parties, right? And people are serving alcohol and people are consuming. Those spaces and places have policies attached to them. We train bartenders. There's hours of operation. There's age limits in terms of going in, right? On December 31st, what do? We provide rides, people home, taxi rides, right? All of that stuff. And so, again, even within our field, we have these, right, visceral reactions to spaces and places. Why? Because we come at it from this higher than mighty place and saying to people, you know what didn't work? Prohibition didn't work. And we know it didn't work, right? Because it didn't we made alcohol illegal and it didn't work. And so we need to take a look at other countries who are doing this from a different perspectives and their outcomes. Portugal, leading with a public health approach to a public health issue. They reduce HIV infection rates by 99%. They reduce opioid overdoses by 85%. We celebrate when we reduce things by 1% or 2%. They reduce opioid overdoses by 85%, with leading with a public health approach. That includes harm reduction, right? That includes harm reduction. Now, that requires a look inward into who we are as individuals, who we are as organizations, as a country, all of that stuff, right? Next slide, please. Now, our roles in supporting harm reduction, here's some thoughts about that, right? We need to understand that substance use disorders and mental health as a public health matter, not a criminal justice issue. And we need to continue to push policies that decriminalize substances. Some people are against that, but we decriminalize marijuana. How many people have died since the decriminalization of marijuana from marijuana? Right? From marijuana alone. Criminalizing people, locking people up has not worked. And at some point, we need to come to that understanding and then not reform and tinker around the edges of a criminal justice system that profits off the misery of millions of people. We need to think about how we recreate systems that are grounded in public health and justice. Because for no other disease on the face of this planet do we lock people up. But for these two, we do. And we continue to do that. And it's reinforced by policies and for-profit processes that continue to penalize these things, right? We need to end punitive approaches. Listen to support, never to judge, right? These kicking people out of care because they're exhibiting signs and symptoms of their disease, that should be a thing of the past. And some of you are saying, well, we don't do that where I work, but it's alive and well. If you ask the clients, the participants, the people that you come in contact with, have you ever been kicked out or pushed out of care? Most, if not all of them, will say yes. Have you ever been treated badly in a space because of your condition? Most of them will say yes, if we're paying attention. We need to support harm reduction as a pathway of recovery and improving health. All people that I've spoken to who identify as being in recovery, and by the way, there are 23 million people who identify as being in recovery in the country from substance use. There are 44 million people who identify as being in recovery from mental health, according to SAMHSA. All of those people, took personal responsibility, are doing something about their pathway. But when you ask them, so in terms of on the substance use end of things, what was your process like in the beginning? They'll say, you know what, I tried to stop, but then I had a reoccurrence, and then I tried to stop again, but I reduced here, I did less bags. So they were practicing harm reduction with very little support and guidance from organizations that are supposed to be supporting that. The evidence says that harm reduction is a viable pathway of recovery for those who are interested in recovery, because not everybody is interested in recovery. And I'll have you know that there are millions more people who stopped using substances and they don't consider themselves in recovery because they don't identify with the disease model of addiction. And I could really care less if they do or don't, because so what? I'm just interested in you getting better. And how can I help you to get better? There's many people from the faith world who did a pathway of faith, and they don't believe in the disease model of addiction because they believe that God lifted the obsession to use, that they're doing other things. And again, if we want to get all high and out, but you have to understand what the evidence is at that. No, I have people that I know close who don't identify with that way, and I'm okay with it. I'm like, how can I help you to get better, right? We need to attend to the trauma and lead with restorative justice around these very punitive approaches, criminal injustice approaches that we have led with. Next slide. I'm coming to the end here. Partner with harm reduction practitioners with experience. Not just say, no, we're harm reduction because we do Narcan. We need to partner with practitioners of harm reduction. We need to use strength-based language. We need to eliminate stigma. We need to humanize people, build equity, lead with empathy and compassion. We need to involve participants in service development and delivery. Notice that I state here from that people with lived experience terminology, involve participants in service development and delivery. We need to develop and implement harm reduction policies within the organization. I can't tell you how many organizations I visited. They say, yeah, we do harm reduction. And they're just, again, doing one or things around harm reduction. And the policies of the organization don't support harm reduction practices on the ground. So again, with the look inward, it's not just about self, it's about the organization. And institutionalizing harm reduction within the organization. That can only happen with policy development, implementation, and ongoing evaluation of those policies. Next slide. That is my final slide here. I know that Daisy must have her hand tired because it's up in the air. But I want to thank each and every one of you for your comments in the chat, all of those things. Christine, how are we doing with time?
We're doing great. You have like 5 more minutes, so you can take questions.
Okay, so we can take some questions. Okay, Daisy, I just saw your thing in the chat. You forgot to bring it down. I thought you had something that you wanted to say. Any other comments, questions, contributions here around harm reduction? This was not really in depth around harm reduction because it's only a few minutes of time that we have. I want to encourage you to visit the mental health, the prevention, the addiction TTCs, not just the ones here in New England, even though we are in the New England area, but others, because there's a lot of resources on harm reduction. Also visit the National Harm Reduction Technical Assistance Center. They have a lot of resources and training, all of that stuff that we can't be all things to all people, and not one organization can provide it all, but we can do a better job of getting to that. Again, thank you for the comments in the chat there. I think Sharon, you have your hand up?
Yeah, hi, I just, it's sort of, in a way, kind of a commentary. It just seemed to be so extremely appropriate that I've done TTC trainings with everybody from the Pacific, Northwest, the other virtual. That's the silver lining of COVID to me. But I just found it particularly appropriate that this is in New England and contributes to some of what you brought up, both in terms of the fact that the opioid crisis, as you said, became a crisis only and largely out here on Cape Cod. Cape Cod became like a center of focus. Not that it wasn't going on anywhere else, but it became so here, not because the Native American communities or BIPOC communities were suffering from it, but because it became a crisis of the white population. And in addition to that, it just occurs to me that it's the same place too that the AIDS or the HIV and AIDS support group has had extreme backlash with regard to securing safety sites. Like everything you were talking about, it's like, well, this is the epitome. I'm not on Keep now, but what was, I just found it kind of striking, that's all. And I thank you for the thorough and informative talk.
Thank you, Sharon, and to everybody else. I'll say a couple of things about your comments and then something else. White, young, affluent people deserve prevention, intervention, the multiple pathways of recovery and recovery supports, and so does everybody else. So does everybody else, right? This is when we lead with equity. This isn't pie. This isn't taken from one to give to the other. In my house, we are as healthy as the unhealthiest person in the house. That's why we lead with equity, because when the most vulnerable, we pay attention to their needs, everybody else gets better. Everybody else gets better. The way that we lead with equity, think about this. You're driving in your car, one tire in your car is flat and one has a slow leak. Which one do you attend to first? You attend to the one that's flat. The slow leak, you'll take care of it later, or you'll deal with it simultaneously, but you have to take care of the flat tire, right? And so when we think about leading with equity, it requires that we do things differently, from what we have done historically. It requires that level of action if we're committed to that. If not, it's just the DEI statements and the DEI committees and the DEI this, DEI that. We took diversity, equity, and inclusion and justice and nailed it down to an acronym. And all of a sudden I woke up and I'm BIPOC. Who the hell came up with that? We love to minimize things, right? And to put them in these little neat boxes that then don't mean anything to anybody. They don't mean anything to anybody. So let's stop with the watering down of things and let's get to the challenging work, because it is challenging, but to the rewarding work of leading with equity and humanizing people, which should include harm reduction at all levels of what we do. I can get on a soapbox and talk forever, but I won't, because we're at time. I want to thank you once again for attending yesterday, for those of you who attended today, and we look forward to your participation in the future as well.
Thank you, everyone. Thank you, Haned, for such powerful presentation. And thank you, Kristen, and your team for a powerful presentation. We will be, again, on our last day tomorrow. So we invite you all to join us tomorrow. And everything that's happened in the past 2 days will be shared within 48 hours. The presentation and the slides. So thank you so much and have a wonderful rest of your day. It's going to be warm in New England today, so enjoy. Thank you. Bye-bye.